A patient can't taste salt on the front of their tongue, but they feel a cotton swab perfectly. No facial droop, no weakness. Which nerve to address? Trigeminal, facial, or hypoglossal? We will discuss 3 high-yield clinical traps that exam writers use to separate the top students from the rest. By the end, you'll never confuse about tongue innervation again. The trap gives you an anterior tongue finding, but they swap taste and touch. Here is classic stem, *, a 55-year-old man. Cannot perceive salt on the left anterior tongue. He can feel a pinprick normally on the same spot. His smile is symmetric. What nerve is damaged? Most students hear anterior tongue and immediately think trigeminal, but that's wrong. As anatomy shows, facial nerve via chorda tympani branch is responsible for taste of anterior 2/3 tongue, while touch, pain and temperature sensations from same anterior 2/3 is carried mandibular branch via lingual nerve. So if taste is gone but touch is normal, lesion is branch of facial. If touch is gone but taste is normal, lesion is mandibular branch. If the stem mentions facial weakness along with anterior taste loss, that spells palsy. But if there's no weakness, the lesion could be an isolated chorda tympani problem. Rare but tested. They give you a posterior tongue finding, and you automatically think, that's rare. Then pick the wrong nerve. Look at this stem example. A 60-year-old smoker reports a metallic taste on the back of his tongue. On exam, his gag reflex is absent on the left side. Touch sensation on the anterior tongue is normal. Where is the lesion? Both taste and somatic sensation of posterior 1/3 of tongue run through glossopharyngeal nerve. Here the gag reflex is the clue. The sensory limb of the gag reflex is glossopharyngeal. The posterior pharynx and posterior tongue efferent is vagus. So if the gag is absent on the same side as the taste loss, that's a glossopharyngeal lesion until proven otherwise. If the stem mentions dysphagia, hoarseness and absent gag, think vagus. As afferent from taste is from glossopharyngeal. If it mentions taste loss on posterior tongue along with absent gag, think glossopharyngeal. Trap 3 relates with the tongue and its deviation, but no signs of stroke. More to decode motor pathway. For example, look at the scenario where a patient presents with difficulty speaking and food falling out of his mouth. When he sticks out his tongue, it deviates to the right. Taste and sensation are intact. What is the diagnosis? Knee-jerk answer is facial palsy, but that is wrong. Tongue deviation is due to hypoglossal nerve lesion, which is pure motor. The tongue deviates toward the side of the lesion. Students memorize tongue deviates to the weak side, but then get confused with facial palsy. In facial palsy, the tongue appears to deviate away from the weak side because of lip incompetence, but that's a pseudo-deviation. True tongue deviation is due to hypoglossal. If the stem mentions atrophy or fasciculations of the tongue, that's a lower motor neuron 12th nerve lesion. If there's no atrophy and sensation is intact, it's still 12th, just not chronic. For anterior 2/3 or front of tongue, sweet, salty, sour and bitter taste is supplied by facial via chorda tympani, while touch, pain and temperature by mandibular branch of trigeminal, via lingual nerve. Posterior 1/3 or back of tongue, both taste and touch are supplied by glossopharyngeal. Very far back, small area vallecular, epiglottis by vagus. Motor for whole tongue movement is via eye hypoglossal nerve. All intrinsic and extrinsic muscles except palatoglossus supplied by hypoglossal. Rule to remember: innervation, or if taste only gone from anterior it's facial. If taste only gone from posterior then 9th nerve involved. If only touch lost it's trigeminal via lingual branch. Both taste and touch gone in posterior part then glossopharyngeal is the answer. If only movement lost then hypoglossal nerve is the nerve. Now your turn to recall. A 45-year-old woman cannot feel a cotton swab on the right anterior tongue. She can taste sugar normally. She has no facial weakness. Her tongue protrudes midline. What nerve is damaged?